Good afternoon, everyone. My name is Filip Sosenko. I'm a research associate at the School of Health and Wellbeing at the University of Glasgow. A few words about my background. I'm a sociologist and a methodologist by trade. I don't have any medical background. I've got 16 years of research experience doing research only, pretty much no teaching. Most of my research has been, in those 16 years, has been on people who are experiencing severe disadvantage, for example, people who are homeless, people who use food banks. And in the last 3 years, my focus has been on people with intellectual disabilities. In the last 3 years, I've been doing exclusively quantitative statistical research, but in the past, most of my projects used to be mixed methods. So that's my background, and I'm just gonna share my screen to start the presentation. One moment, there we go. Can everyone see this front slide?
Yep, perfect.
Okay. Most of this presentation will be about COVID and people with intellectual disabilities, but I will also spend some time talking about a second leg of this project, which was COVID and people with autism or adults with autism. As you can see, quite a lot of names. So I'm just one of a much larger team of people who've had input into this study. There we go. Presentation structure. So there will be 3 parts. The biggest part will be about intellectual disabilities, then about adults with autism, and lastly, I'll talk briefly about a little kind of experimental offshot of this larger project where we were using the COVID-19 case to argue for a bespoke comorbidity index in people with autism. The paper on COVID and people with ID was published recently in October, and 2 papers on autism are just about to be submitted within a few days. So I'll go ahead as there are a few slides to cover. So COVID-19 outcomes among adults with intellectual disabilities. The background to this research is that all previous studies that have been done found increased risk of COVID-19 death among people with ID. Those studies, there are a few gaps in evidence, despite there being 4 or 5, studies into this into COVID outcomes among people with ID. So those early studies basically covered just the beginning of the pandemic. So either spring 2020 or spring and summer and autumn 2020. One study covered the period up to February 2021. So basically, we have some evidence from those first stages of the pandemic, but we don't have a picture for the whole main period, by which I mean before Omicron became dominant. So, which is around the beginning of 2022. So there is lack of picture for the whole main period of the pandemic. And the other gap in evidence is that those early studies were fairly limited in their investigation of the factors driving negative COVID outcomes among people with ID. And particularly, we know that people with ID have much higher levels of multi-morbidity and polypharmacy than the general population. And those things weren't really investigated in those early studies. And obviously, because those early studies focused on 2020, the role of vaccinations couldn't be investigated by those studies. And also importantly, when it comes to modeling risk factors, two early studies tried to model risk factors, but one kind of weakness of those modeling attempts was that the researchers did not have PCR testing data, so they could really not distinguish between someone who never was exposed to COVID and someone who was exposed to COVID and then stayed at home and for a week and then just recovered. So why this new research? Pretty much two motivations: to cover the whole main period of the pandemic and not just the beginning. So our study covered all of 2020 and 2021, and the cutoff point was the last day of 2021. But probably more importantly, we wanted to increase our understanding of factors responsible for the higher risk of severe COVID outcome among people with ID. So that's where we spent quite a lot of time and effort. And we were fortunate to have PCR testing data, and that's what we used in our modeling. We would argue that our results have this advantage over previous efforts because we could use this PCR testing data. Just a quick list of research questions. It's a mixture of what, how, and why questions. So firstly, about mortality. How does COVID-19 mortality among adults with ID compare with that of the general population? Then the same thing, but for hospitalizations, COVID hospitalizations. Then we move on to risk factors. So what are the risk factors when it comes to COVID death or COVID hospitalization, and whether there are any differences between risk factors in the ID population and the general population. Then what factors are key drivers of severe COVID? And lastly, what factors are responsible for the higher probability of severe COVID among adults with ID? And here by severe COVID, we mean either COVID death or COVID hospitalization. A couple of words about the methods. So the study was part of the COVID Impact Consortium coordinated by the British Heart Foundation. We accessed data through NHS Digital's then trusted research environment, and currently it's called a secure data environment. We had several data sets available. So we had hospital admissions, death certificates, PCR test results, COVID vaccinations, primary care interactions, and prescribing prescription medication. We linked those data sets using an already created unique identifier, and we did various statistical analysis on that linked data set. Altogether, we had 10.5 million unique people with confirmed COVID in that final linked data set. That includes adults and children. There were about 8.5 million adults and 2 million children, but we decided to focus on adults only, and I can talk later at Q&A about why we didn't focus on children, at least not at that particular time. So moving on to results. So a few descriptives. So here we have adults with ID and adults without ID. We can see, as probably most people would expect, that there were proportionally fewer females among adults with ID. And the second row is quite interesting. So by the time someone got infected with COVID, there were proportionally fewer people with ID were vaccinated at least once, so 43% versus 51% of adults without ID. So there were fewer people were vaccinated among people with ID. And another interesting difference was that proportionally more adults with ID were vaccinated with AstraZeneca, and proportionally fewer were vaccinated with Pfizer than in the general population. Then we counted long-term health conditions and prescription medication, and we can see that people with adults with ID had double the values for the general population. So so that's I mean, it's probably for most people it's not surprising, but it was just confirmed with in the data. So moving on to the first research question, COVID-19 mortality among adults with ID. So what's important in this table is that by the end of 2021, slightly over 2,000 people with ID, adults with ID, died due to COVID. And that was more or less a little bit more than 0.5% of the starting population. So say in early 2020, just before COVID. So 0.5% of people with ID, adults with ID, died of COVID, which is about one in 180. And that was, in crude terms, slightly over twice the risk of dying from COVID in comparison to the general population. And when we then did standardization for age and sex, the difference in the risk was even higher. So people with ID had over 5 times the risk of dying from COVID than people without ID. So yeah, SMR is standardized mortality ratio, and that was 5.6 until the end of 2021. So yes, standardization for age and sex makes quite a big difference. So I mean, the crude risk was already a lot higher. 2.1 is a lot higher risk, but it really goes a lot up after standardization for age and sex. The second research question was for hospitalization, same thing, but for hospitalizations. And what we can see here is that by the end of 2021, 2% of people with adults with ID were hospitalized, which is 1 in 50. And here the risk ratio with regards to hospitalization was 2.4 in crude terms, and after standardization it was 3.6. So these are just kind of that's what our first aim was, to get a picture for the whole main period of the pandemic, and that's what we these figures achieve. They got us to this aim. But then there was this equally, if not more important, set of questions around risk factors. So we did modeling where the outcome was the presence or absence of severe COVID, so COVID hospitalization or death, and we used quite a few predictors in our modeling, and what this table shows, it was a logistic model. So what we have, the values here are odds ratios, and what we can see is that all of these predictors were statistically significant. With it, one model for adults with ID and one separate model for adults without ID. So what we can see is that age was a significant predictor. So the older one is, so that's each year of age increases the odds by this value in people in ID versus people without ID. And so the older one is, the higher the risk of severe COVID outcome, where the being a female lowers the risk. Being from a non-white ethnic background increases the risk. Being vaccinated decreases the risk, particularly if someone was vaccinated with Moderna and Pfizer. AstraZeneca was not it was still protective, a protective factor, but not as much as Pfizer or Moderna. Long-term conditions. So here we are talking multi-morbidity. Yes, the higher the count of long-term health conditions, the higher the risk of COVID death or COVID hospitalization after infection. And similarly for with polypharmacy, but the coefficient is much lower on polypharmacy than on long-term conditions. And what's interesting about this table is that the coefficients are pretty much similar between people, adults with ID and without ID. What is where there is a slight difference is here, where the effect of AstraZeneca. So being vaccinated with AstraZeneca had a more protective effect on people without ID than on people with ID. Yeah, here the lower this number, the more protective kind of the more the risk decreased. So that was interesting to find out results of this modeling, but obviously model coefficients don't tell us which factor really is more important than others. So what we did, and we were obviously interested in key drivers of severe COVID outcomes. So what we did is we did hierarchical logistic regression, and we looked at something called pseudo R squared, and we looked at pseudo R squared values when the model was more and more complex, when we added more and more predictors. So we started with a bare model where there are no predictors. Then we added age. Then to that model with age, we added sex, then ethnicity, and so on. And what we are looking for, for instances where these numbers would jump in a quite significant manner. So here, a model with no predictors has 0 pseudo R squared. So then there is quite a big jump from 0 to 0.11. But then when you add sex to age, it only adds a very little to that previous value. So sex is not a key driver, but age is definitely a key driver. Ethnicity doesn't add much. Area deprivation doesn't add much. Then there is another big jump when we add vaccine information, another big jump when we add multi-morbidity to the model, and then just a very, very little increase when we add prescription or polypharmacy information. So based on this table, we could say that the 3 key drivers of severe COVID are age, multi-morbidity, and vaccination status. And there isn't really much, and it's the same for adults with ID and adults without ID. Those 3 things are key drivers of severe COVID in both ID and no ID populations. And lastly, we were interested in what factors are responsible for the higher probability of severe COVID among adults with ID. It may look unfamiliar, this plot. It's from it's a plot from some statistical technique called Blinder-Oaxaca decomposition. But basically, we can have the different probability of some kind of outcome could be either due to a different prevalence of some risk between two groups, or it can be due to a different effect size of a given factor in the two groups that we are comparing. So the top half here is about prevalences or distributions. So say a different distribution of age, a different distribution of sex and ethnicity and so on. And this plot tells us how much of the difference in probability of severe COVID between adults with ID and adults without ID, how much of it is due to the prevalence of each of these factors. So here clearly a big factor that is responsible for this higher probability in a big way is the count of long-term conditions, so multi-morbidity. Other things are less important. And the bottom half coefficient, so it tells us how much of the difference in probability of the outcome can be attributed to different effect sizes of different factors. So here, what it essentially tells us, this bottom half, is if the gap, the risk of severe COVID outcome among people with ID would be even higher if the effect of age on severe COVID was, if the coefficient, the age coefficient was higher among people with ID. Maybe I'll let me see if I can. Yeah, I think if I go back, you can see that there's this coefficient is lower among people with ID than among people without ID. So that's what this refers to. Right. I'm conscious of the time running. So the implications to us were that definitely people with ID have a higher risk, whether accrued or age and sex standardized, have a higher risk of negative severe COVID outcomes. So they should have priority in vaccination programs, such as COVID booster vaccinations and so on. If there was a choice of vaccine, we would our study suggests that it's better to give people with ID either Moderna or Pfizer, than AstraZeneca, because AstraZeneca was slightly less effective among people with ID than people without ID. A kind of research implication of our study was that we should really try to understand multi-morbidity among people with ID better and have more knowledge about it and more understanding of it, because we know well that people with ID have much higher levels of multi-morbidity than people without ID, but what part of it is attributable to genetic factors, what part of it is attributable to social factors. That's what that's the research direction in which I personally want to go, and we are kind of starting a research program around this at the Scottish Learning Disabilities Observatory, where I'm based. That's the presentation. This is just a screenshot from the BMC Public Health website, where there is you can access openly the paper on people with ID and COVID outcomes. The paper on people with autism and the bespoke multi-morbidity index, they will be submitted in the next few days. So yeah, I'll stop share. Shall I stop sharing? Yep.
That was great. Thank you, Philip. That was really interesting. We do have a few questions for you already in the chat. So I'll start with Shukras. Apologies for my terrible pronunciation. So she's saying, I'm currently working on investigating the impacts of COVID-19 in people with multiple long-term conditions. I would like to know how you defined your list of long-term conditions that you included and how many LTCs did you include?
Yes, so we had 35 long-term health conditions, and they plus ID was treated separately, and we took that list from. Sorry, I would need to have a quick look at the. Just 1 second. I'm just because I don't want to. I'm just gonna tell you which source was it. That was from Castle, Edwards, and Harshfield, the epidemiology of multimorbidity in primary care at retrospective cohort study. They've used and argued for that list of 35 long-term health conditions. And we took phenotypes from Cambridge multimorbidity score. So we really kind of really tried to rely as much as possible on acclaimed or very robust work of people before us. So we didn't try to kind of revise any phenotypes or come up with our own list of long-term health conditions. We just used what's existed. Yeah, so it was 35 long-term health conditions. If I could, let me have a look if I can share this. If I could share this the screen to show. Okay, maybe 1 second. I'll see if I can. Well, I've got a table here, but with some numbers. So I don't think I can share that at the moment. But yeah, it's the. I think you would the questioner would
I think
recognize.
they have responded to say that it was very helpful. So I think that's great. So there's another second part to that question as well. So what was your time frame for the early part of the COVID pandemic, where you reported the mortality and hospitalizations?
What I meant was that by the time we started our project, the studies that existed by then, they used data from early stages of the pandemic. So yeah, like the first wave or the first 2 waves of the pandemic. Whereas we wanted to look at to have the whole picture, but without taking into account the time when Omicron was already dominant. So we decided to settle for the end of 2021 as the cutoff point. So yeah, our figures are for the whole of 2020 and the whole of 2021. And in the paper, you can find those figures broken down by 2020 and 2021 and the whole period. It's quite nice that the vaccinations started being rolled out in December 2020. So this division 2020 versus 2021 is quite a neat one, and it's a justified way of breaking down the whole timescale into 2 because of the vaccinations.
Brilliant, thank you. Okay, so Richard has commented just to say thanks for the presentation, very interesting. He's wondering about the total number of ID patients, roughly 350,000 ID out of 60 million with no ID. This is roughly a prevalence of 0.5%, much lower than other figures of 1.5 to 2%. Would you have any insight into the reason for this difference? Did you have a look at severity of ID, e.g. mild, moderate, severe P&M? I'm just starting research, so this would be really useful.
Yeah. So yes, we are very well aware that our estimate is our the percentage with ID that in the data set that we used is lower, definitely lower than estimates, say, from educational sources and so on. But there isn't really much that could be done. So we used GP records, and we used a learning disabilities register to identify people with ID. So my only explanation is that the missing people are people who've never had a diagnosis of learning disabilities when they've been seen by a GP, and why that is, it's a big thing, and I don't want to claim that I know much like enough about it to talk about it, but yes, there is, like, particularly people with mild or borderline learning disabilities. That's where the under coverage or under diagnosis lies.
Okay, perfect. Right, so we are just about to run out of time, but I think I have one other very short, hopefully short question. And then just to say just now, if we haven't answered any of your questions, please let us know, and we can get in touch with Filip and send a response directly back to you. But I'll make this the last question. So this is from Brenda. Was AstraZeneca generally given at earlier dates when treatments were not available or not understood?
Sorry.
So
I'm
was
looking at
Astra?
chat.
Oh, sorry. Was Astra? This is. I think this has come in another way, so it's not on the chat.
Okay.
So, was AstraZeneca generally given at earlier dates when treatments were not available or not understood?
Well, so AstraZeneca was the first vaccine to be rolled out, but there shouldn't be differences in people with ID and people without ID as to, we would expect that proportionally the same proportion of people with ID were vaccinated in January 2021 as the proportion of people without ID. We wouldn't expect there to be like some kind of major differences. So, for example, because like what could be the case is that I don't know, when vaccines were first rolled out, it was people with ID were somehow ended up, proportionally with a better chance of being vaccinated in the early weeks of the rollout. But I don't have any figures whether confirming or rejecting this claim, but somehow they ended up getting proportionally more AstraZeneca than people without ID. But yes, this is something that has kind of puzzled me, and if I had time, I would probably spend more time and effort digging into that.
No, that's brilliant. Thank you. Well, thank you, Filip, for a brilliant presentation. I'm going to call it there because we're running out of time. But if anyone does have any questions, as I say, please let us know. And we'll also share a link. And this talk will be available on the HDR UK YouTube channel. So thanks again, everyone, for attending today. And thank you, Filip.
Thank you very much.